In this lecture and in the corresponding reading from your text, we're going to talk about some of the broad concerns and goals of assessment. And of course, if we think about what is the most basic purpose of assessment, I think most people would say in order to achieve some diagnosis. In other words, to tell a person what kind of problem they have. Is it aphasia? Is it apraxia of speech? Etc. And when it comes to communication problems, aphasia, apraxia of speech, dysarthria, as speech pathologists, I think we're really the best equipped to make those accurate diagnoses. One point I'd like to make is that just to remember that we don't diagnose disease processes. We diagnose the impairments, the disabilities that arise from disease processes. So yes, it's fine for us to make a diagnosis of aphasia. Aphasia is due to stroke. We wouldn't diagnose that they've had a stroke. With dementia, it can be a little bit trickier because there wasn't an abrupt event that happened, and so sometimes patients come into the clinic not really knowing why they have the problems that they're having. But dementia is a disease process, and that's a diagnosis that needs to be made by a medical doctor. We can make a statement in our reports, something akin to the person presents with this pattern of cognitive or communication problems, and this is or isn't consistent with a diagnosis of dementia, Parkinson's disease, ALS, whatever. Because we're largely a treating profession, probably a more important reason for us, or one of the main purposes of our assessments, is to try and understand what to do in treatment. And of course, generating a diagnosis is part of that. But other things that are important are, for example, not just labeling somebody with aphasia or Broca's aphasia, but doing the kind of assessment that might help us pinpoint as precisely as possible what underlying cognitive or linguistic processes are damaged and are causing the symptoms that we're observing. Also, I think when we assess, we kind of become aware of a patient's different strengths and weaknesses within the domain that we're testing. This is important because in general, one principle of rehabilitation is that we always take advantage of strengths, either as means to communicate on their own or as ways to support other functions which are weaker. Other reasons for assessment is to establish goals. Now, I don't want to mislead you into thinking that assessment is necessary to establish goals. Depends on the context. Let's take, for example, a person who's had their stroke 3-5 years ago. They're very well familiar with their disability. They've been in treatment before. We always have limited amount of time to assess. So for a patient like that, I may spend a lot more time right from the beginning, establishing a rapport with them, trying to get an idea of what their goals are. Right? This is what we would call client-centered goal setting. The benefit of that process is not just that there is this rapport building, but also that my assessment now can be more refined. I can take that limited amount of time that I have and be as efficient as possible at directing assessments that are directed towards the patient's goals and how to help them achieve those goals. And then, of course, finally, traditionally, assessments, we also make some prognostic statement in terms of the person's likelihood, how well they are likely to respond to treatment, recover, etc. Now, assessment can be very context dependent, and I've already kind of alluded to that with the discussion of treating someone who's had their stroke 3 to 5 years ago. But the context that we're typically looking at is acute care, that care that a person gets immediately after they've been admitted to the hospital with their traumatic brain injury, their stroke, etc. Acute rehab, which is after they've become medically stabilized, they go usually to another ward on the hospital where they get at least 3 hours of therapy a day, intensive therapy, not necessarily 3 hours from us, but 3 hours from the therapist, OT, PT, speech, etc. After usually 2 to 4 weeks of acute rehab, a person goes to subacute, right, which may be a outside facility that can provide 1 to 3 hours of therapy a day for the patient, still fairly intensive because it's daily. Or the patient, particularly this happens for our patients, if they're ambulatory and their problems are really just cognitive linguistic, they may go home and then we'll see them as an outpatient. Now, if I get a consult for somebody who's in the ICU in acute care and it asks me to assess their speech and swallowing, of course, my main focus will probably be on swallowing because I want this person to remain safe and not have any medical complications from aspiration that may prevent them from recovering. I probably will only really screen speech and language because A, I know that their speech and language may change rapidly over the next few days. B, the patient is usually really not medically ready. They're not alert enough. There are many other medical issues going on. They're just not ready to engage in any kind of real meaningful treatment. So I really am screening to make broad statements about whether there's the presence of aphasia, whether it appears to be severe or mild, or whether they have dysarthria, etc. Educate the family members about what aphasia is, what they might expect as they move into acute rehab. And then perhaps I can make some practical statements to the family or the nurses and doctors about how best to communicate or support this person's communication. Once they move to the acute rehab ward, and I'm seeing them every day, in some ways, I think that one of the general philosophies in acute rehab is taking a restorative approach. And what we mean by a restorative approach to rehabilitation is that we're trying to restore the function that's been impaired to as close to its premorbid status as possible. So in the context of aphasia, this will look a lot like stimulation types of treatments. So for example, if I have identified, because when that person moves to acute rehab, I am going to start to do a much more comprehensive evaluation, an evaluation that will hopefully allow me to identify in the person with aphasia if they have semantic problems, phonological problems, etc. If I identify, for example, that they have semantic problems, then my treatments may be more focused around semantic stimulation. Now, that's not the philosophy of every acute rehab speech clinic. Some clinics, I think, tend to move right into focusing more on compensatory ways of dealing with the communication problems. But there is some literature out there suggesting, I think, that intensive stimulation-based treatment in acute rehab improves the overall recovery that a person is going to make in the future. Once that person is discharged home, well then I think it's much easier, for example, to engage in client-centered goal setting, because the person is beginning to have some experience of how their TBI, their attention problems, their executive function problems, or in the case of aphasia, their word-finding difficulties, etc., how those problems interact with the world. In other words, what are they not able to do now that they used to be able to do? And out of all of these things that they can't do anymore or as well, what are the ones that are really important to them that they want to start doing as soon as possible? Well, see now, at this point, I may be starting not with an assessment per se, but with talking about goal setting first, and then having a focused assessment based on the patient's goals. Within a rehab team or a medical team in general, or a collection of healthcare providers in an outpatient context, there's some overlap between what we do and what some other professionals do, particularly when it comes to assessing cognitive impairments. I think we are really the experts and the ones who should be making statements about communication impairments. Neuropsychologists typically do very in-depth 3, 4, 5 hour-long exams in an effort to, as completely as possible, quantify not just the cognitive and linguistic problems that a patient has, but also cataloging the comorbidities that might affect their cognitive performance, such as depression, some psychiatric illnesses such as schizophrenia, which is on its own associated with cognitive difficulties. Neuropsychological reports are great. When I was at UCLA, I formed an arrangement with the physicians referring to me and the neuropsychologists that for certain types of patients, they would see them first, do their exhaustive testing, and then I would see the patient. So I would have the benefit of looking at all of that in-depth testing, and then I could kind of then cherry pick, again based on the client's goals, etc., more focused, efficient assessments that were really designed to help me develop a treatment plan with the patient. Neuropsychologists, in my experience, basically rarely treat. Occupational therapists often will assess cognition, but they're usually in the context of how it affects a person's ability to do activities of daily living, which are things like brush their teeth, getting dressed, cooking for themselves, etc. As far as getting referrals from patients, I think it's our job as a clinician within our speech pathology clinic to occasionally do things to grow our referral base. And so, for example, that can be either by developing relationships with the people who refer to us, the physicians in the hospital, on a one-on-one basis, or doing things like giving in-services. So, for example, right hemisphere damage patients, as I've mentioned, very under-identified, under-treated population. So with that in mind, I could come to the neurology department or the rehab department and say, hey, you know, I think this is something that you guys need to know about. I have a presentation prepared. I'd be happy to do it for you. And usually they're quite open to that. And, you know, that is a good opportunity for us to demonstrate our expertise to other professionals who I think often aren't really aware of what we do. But oftentimes, in my experience, what you'll see is at least for a short period of time, you'll see more referrals coming to you from the neurologist that you gave the in-service to. More right hemisphere damaged referrals, etc.